Welcome back to the deep dive. Today we are really digging into the playbook that runs every emergency medicine training program, the RCEM 2021 curriculum.
We are.
And we're zeroing in on, I think, the cornerstone of hands-on skill development specialty learning outcome 6, SLO 6.
This is a crucial deep dive for you, whether you're, currently logging cases, preparing for an ARCP, or even if you're supervising trainees.
So our mission today is really to cut through the complexity.
Exactly. To give you that longitudinal roadmap from ACCS right through to ST6, showing exactly how procedural mastery is defined, achieved, and importantly, sustained.
We've got stacks of source material here, and the first thing that just jumps right off the page is that we are looking at a total paradigm shift. It's not just tweaking the boxes we tick.
Oh, absolutely. If you take one strategic nugget away from this discussion, let it be this. The curriculum fundamentally elevates assessed quality over mere procedural volume. It is no longer enough to just log 50 of a procedure in a database. I mean, that's gone. Progression now hinges entirely on a verifiable demonstration of competence.
And that's measured by something specific.
Yes, measured explicitly by the RCEM Universal Entrustment Scale.
Okay, let's unpack this new foundation, this idea of entrustment and deliberate practice. Before we get into how you prove the skill, what's the actual scope of SLO6? What procedures are we even talking about?
Well, it covers the whole range of psychomotor procedures that are fundamental to EM practice. And it stratifies them, really, by risk and complexity across your training journey.
So if you're in core training, ACCS, you're focusing on the foundational stuff, the resuscitation and acute interventions.
That's right.
So we're talking about basic life-saving skills like pleural aspiration of air, chest drain insertion.
Both Selding and open techniques, yes.
Right. And things like establishing invasive monitoring with ART and CVP lines, and then basic point of care ultrasound.
Your vascular access, your fascia iliaca block. The essentials.
But then it ramps up.
Precisely. As you progress into intermediate and higher training, so ST3 through ST6, the curriculum demands competence in advanced, high-stakes, and crucially, often low-frequency, high-acuity procedures.
LFHA interventions.
The LFHA procedures. The ones you might perform maybe once or twice a year, but when you do, the stakes are maximal.
So resuscitative thoracotomy?
Resuscitative thoracotomy, lateral cathetomy for vision loss, pericardiocentesis, and even resuscitative hysterotomy, the big ones.
We've all got that classic logbook, stuffed with numbers. So why did logging, say, 10 pericardiocentesis procedures fail us? What was the fundamental flaw in that volume count thinking?
It failed because it gave a false sense of security. I mean, that's the bottom line.
Right.
Logging an event simply records exposure. If you logged a high-acuity event 18 months ago, that log entry tells us absolutely nothing about whether you retained the skill, understood the indications, or could recover from an error today.
So it's not durable.
Not at all. The sources are so clear on this. Patient safety requires competence that is durable and verifiable, not just a tick in a box from a year ago.
So the solution is more formalized, structured learning. The curriculum calls it deliberate practice and simulation-based mastery learning, SBML. That sounds like a heavy administrative title. What does it actually mean for a trainee on the shop floor?
It just means structured effort. It's moving beyond just showing up and hoping a case walks in.
Okay.
It involves structured repetition, escalating difficulty under expert coaching, getting focused feedback, and having protected time for reflection. And all of this is ideally done in a low-stakes environment like a simulation lab. SBML just formalizes it.
It makes perfect sense for acquiring the skill initially, but here's where it gets really interesting for me. We're dealing with the harsh reality of emergency medicine, the experience curves. We are constantly fighting that forgetting curve.
That is the longitudinal challenge. The curriculum finally recognizes that many of these high-stakes procedures are just infrequent.
You just don't see them.
You don't. So relying solely on clinical exposure to maintain competence is simply insufficient because those finely tuned skills, they degrade, and they degrade rapidly. So the whole roadmap is about ensuring the durability of competence.
Let's move to the tool that governs this whole process then. The RCEM Universal Entrustment Scale. This is the core mechanism the language supervisors now have to use to describe a trainee's capability.
Correct. It's a 5-point scale, level 1 up to level 4. Level 1 is needing immediate supervision, and level 4 is, expert or entrusted autonomy.
But the unique thing and the critical thing for you to grasp is how it's defined.
Yes. The definitions are based explicitly on the location or availability of the supervisor, not just vague descriptors like good or needs practice.
Can you walk us through those particularly the middle levels, 2 and 3.
Certainly. So level 1 is direct observation. I'm right there, ready to take over. Level 2A means I'm immediately available on the shop floor in the ED checking in. Level 3 is a huge leap. The supervisor is on call from home. They can direct you by phone, but they're expected to come in if needed. And level 4 is you're on your own. You're entrusted as an independent practitioner for that specific task.
Now, I've heard level 2B described as the most important cognitive hurdle to cross in training. It's what separates the competent from the truly safe. What does 2B demand that 2A doesn't? It's not just about proximity, is it?
Not at all. That's the key misunderstanding. Level 2B states the supervisor is within the hospital, able to assist promptly, and this is the important part. The trainee must reliably demonstrate solid judgment about when to ask for help.
Ah, so it's a non-technical skill.
It's pure non-technical skill assessment. Level 2B explicitly mandates the assessment of your self-awareness, your insight, your situational judgment. It's moving from assessing pure technique to assessing clinical wisdom.
That distinction, technical versus clinical wisdom, brings us straight to the admin side of things, the paperwork. So if I nail the DOPS, the direct observation of procedural skills, that's only half the battle. What's the other crucial administrative hurdle for ARCP?
That is the dual assessment mandate. You absolutely have to separate the assessment of what you do from how you think.
Okay.
So technical skill, the physical steps, that's assessed by the DOPS. And these must be correctly filed under SLO 6. That shows you can do the thing.
But the cognitive, the contextual skill, understanding the indications, complication management, the overall judgment, that gets assessed somewhere else.
Exactly. That broader clinical judgment is filed typically under SLO 1, clinical judgment. You use broader tools for that, like a mini CEX or CbDs or an ACAT. This separation is mandatory. It ensures competence is verified in both performing the procedure and applying it safely.
And if you don't do that,
It's an ARCP risk. Simple as that.
okay, to structure this journey, the curriculum formally integrates the OASIS progression model. How does OASIS organize the learning process?
OASIS stands for Observe, Assist, Supervise Performance, Independent Performance, and Supervise Others. It's the best practice framework that really synthesizes the mastery learning with that entrustment scale we just talked about.
And crucially, it mandates specific preparatory simulation steps at key points.
Yes, to enhance patient safety. It's no longer see one, do one, teach one.
So we're replacing that hope of opportunistic learning with a deliberate two-step simulation mandate. What do those two mandatory steps actually involve?
This is key for program directors. Look at the assist phase, which is OASIS Level 1. It now requires a preparatory task trainer step.
So before I even try to pass a wire for an art line on a real person,
You must practice wire handling and the subtasks on a low-stakes simulator until you've demonstrated proficiency. No question.
that makes so much sense. And then for the next big phase, supervised performance, level 2A or 2B.
Before performing the complete, full-risk procedure on a patient, the trainee must complete a preparatory simulated performance step,
A full dress rehearsal.
a full dress rehearsal in a high-fidelity environment. And this isn't just about technique. It focuses on decision-making, team communication, recognizing errors, and complication recovery, all coached by expert faculty. Mastery in SIM must precede live performance.
It eliminates that dangerous first attempt on a patient. And the final, highest level of this framework, OASIS Level 4, supervise others.
Yes, Level 4 is the ultimate expression of entrustment. The senior trainee is teaching and supervising junior colleagues, always under faculty oversight, of course.
And that's not just about developing them as an educator.
No, it's one of the most powerful tools for reinforcing and securing the senior trainee's own procedural retention. The act of teaching requires a deeper, more reflective level of mastery.
Let's zoom in on a highly technical and mandatory component of SLO 6, Point of Care Ultrasound, PoCUS. The curriculum outlines very specific milestones here.
They are non-negotiable. PoCUS is mandatory and it's structured longitudinally. So in ACCS, you start your logbook, you get signed off on the basic procedural stuff like vascular access and the fascia iliaca block.
But there's a critical hard stop.
There is. The end of ST5. That's the critical deadline.
What needs to be done by then?
By the end of ST5, you must have signed off all mandatory diagnostic modalities. ELS, the extended lung study, AAA for abdominal aortic aneurysm, and EFAST, or FAFF. Missing this ST5 milestone really risks your progression.
We mentioned volume counts failing us earlier, so what is the definitive RCM position on scan volume versus entrustment for PoCUS?
This is where the curriculum is brilliantly explicit. While there are indicative numerical targets, You'll see numbers like 25 scans for AAA and 10 for ELS in the guidance. These are only guides.
Desk guide.
Yes. The primary determinant of your progression is the supervisor recording your verified entrustment level. The quality of competence attained, measured against the entrustment scale, overrides raw volume statistics. End of story.
That emphasis on quality must demand really rigorous documentation, far beyond just logging a time and date. What are the specific administrative hurdles for PoCUS?
There's a much higher requirement for reflection and for clinical governance. You need a detailed logbook with specific reflective notes for each diagnostic modality 5 for AAA and ELS, for example.
And for governance.
Every single diagnostic scan you perform must be formally reported, either in the patient notes or on PoCUS. And this report must explicitly state your level of competency according to that RCEM Entrustment Scale.
So if I do an EFAST, I have to document not just my findings, but that I performed it as, say, a level 2A or level 3 operator right there in the patient's record.
You do. It's a significant step, but it's vital for safety.
And this all culminates in an integrated assessment, right?
It does. The Shock Protocol Integrated Assessment is a major requirement at ST5. It tests your ability to synergistically use findings from multiple PoCUS modalities, ELS, AAA, EFAST, to interpret the whole clinical picture and manage a critically ill patient.
So it's not just about siloed skills.
No, it's about synthesis and decision-making in a high-fidelity scenario.
Moving into the highest levels of training, SD4, 5, and 6, the struggle shifts a bit. It's no longer about gaining competence, it's about sustaining it, especially for those high-stakes, low-frequency procedures. How does the curriculum mandate that we combat skill decay?
The training program itself must embed mandatory scheduled refresher simulation sessions throughout ST4, ST5, and ST6. The sources are absolutely clear on this.
So achieving level 3 once isn't enough.
Not nearly enough.
Yeah.
Programs have to proactively schedule these reinforcement sessions based on those experience curves to stop skills from degrading before the next clinical exposure, which might be months away.
That's the mandate. But implementation is always the hard part. The sources highlight a pretty significant governance challenge, that the entrustment scale, though brilliant, is frequently misunderstood and applied inconsistently.
That's true. We see it all the time. The variability in assigning levels really undermines the whole system.
So what's the solution?
Mandatory, recurring supervisor calibration sessions. These sessions are vital to clarify the explicit behavioral anchors that distinguish each entrustment level.
And they need to focus on that key judgment call.
They need to spend specific time focusing on reliably assessing level 2B judgment. That is, understanding the trainee's demonstrated self-awareness and when they escalate.
So standardized assessment needs standardized training for the assessors. Finally, for program directors and educational leads listening, what is the key resource commitment needed to make SLO 6 successful?
It's transition. It's moving the budget and resources away from solely relying on opportunistic clinical exposure. That model is dead.
So what's the new model?
Program directors must secure dedicated resources. I'm talking budget, high-fidelity simulators, task trainers, to support those mandatory preparatory simulation steps. They're dictated by the OASIS framework.
It's a necessary commitment.
It's essential to move beyond minimum compliance towards verifiable competency for all EM trainees.
That is a phenomenal outline of the shift in procedural training. I think the key takeaway is indisputable. Achieving SLO 6 is now a structured, longitudinal journey governed by verifiable competence and specific simulation steps, not just tallying up procedural counts.
Exactly. And building on that concept of experience curves and the durability of competence, we have to leave you with this provocative final thought. If the highest level of entrustment, that OASIS level 4, supervise others, is the most powerful tool for enduring procedural mastery in senior doctors, how often should clinical departments formally mandate this educator role to secure long-term safety across all high-stakes interventions?
Something critical to mull over as you schedule your next calibration session or file your next DOPS form. Thank you for joining us on this deep dive into the 2021 curriculum.